This episode of Around the Rheum was generously supported by Choosing Wisely Canada and the Royal College Foundation.
Different people will have different motivations. So some people will be motivated by the philosophy of it, by wanting to have a green office, by caring about planetary health. And other people may be motivated more from the business perspective. Is there a way that you can appeal to that aspect, the business person aspect of running a rheumatology practice? Are there cost savings to be had here?
Yes, so there's definitely cost savings. So I actually emphasize to people as well, there's often a perception that, quote, doing the right thing is going to cost you more. It's actually not the case when it comes to a lot of these efforts. Because typically if you purchase less things or you're throwing out less things, you're actually usually saving money. So some studies have actually suggested that in an ambulatory care setting, you might be saving $2,000 to $4,000 a year. For example, in rheumatology, things that have to be in person is joint aspirations and injections. So these are procedure things that we typically do. So what ends up happening is that anything that's considered biohazardous or that you throw in biohazardous, it's incinerated. So it costs money to dispose of it once it's biohazardous. So all those sharps containers that we have, the whole thing is incinerated. From a business perspective, it can range from, hey, we're now using LED light bulbs. It's going to last longer, going to be more efficient, depending on what you're paying for, whether it's like your rent or your electricity or water bills. There's definitely ways people can streamline. And also, if you're no longer purchasing exam table paper, so you just get rid of it completely. The most cost efficient and also from a patient care perspective is spraying it and just wiping it down, reusable cloths and washable cloths. That's actually costs less overall than buying rolls and rolls of paper and getting rid of that, or just dumping things. So if you separate things at the user level, separating things that is just regular waste versus biohazard waste, there's definitely gains to be made from that standpoint too. And hospitals are realizing that even at the hospital level, some studies say that up to 85% of waste can go to the landfill safely. It does not need to be incinerated. So these are the gains that definitely work at the clinic level, but also at the hospital level.
That's Dr. Stephanie Tong. She is the Rheumatology Division Head at Trillium Health Partners in Mississauga, Ontario. She is the current Vice President of the Canadian Rheumatology Association Board of Directors, and she is a lecturer at the University of Toronto. And as if all that wasn't enough, in 2022, she led the creation of a Planetary Health Committee that has now published a toolkit to help rheumatologists lessen our climate change impact, which is actually quite a bit bigger than you might think. We are thrilled to have Stephanie as our guest on this episode of Around the Rheum. Welcome, everyone. I'm Daniel Ennis, and a warm welcome back to my fabulous co-host, Dr. Janet Pope. Janet, how you doing?
Very well, and I'm really excited about tonight because I think we can make positive change.
I'm really looking forward to your thoughts on all of this. So maybe what we'll do now is get Dr. Tom to help explain why we are talking about this today and what rheumatologists can actually do. So Dr. Tom, welcome to the show.
Thank you for having me.
It's a real pleasure. You and I have crossed paths here and there in the past, and I've always thought you were a very insightful rheumatologist. So I'm very curious how for you to explain your journey a little bit. But maybe the best place to start is the defining terms a little bit. So can you explain in broad strokes the concept of planetary health?
Yeah, for sure. So planetary health really refers to a multidisciplinary approach to how to address the impact of human activity on the environment. But another term that people have used is sustainable healthcare, the idea that we can implement our services in an eco-friendly lens. And the best news is that typically this results in cost savings to the healthcare system, which is very timely.
I guess I had never really, and this is just my own ignorance, I hadn't really considered the contribution of healthcare to kind of climate change and planetary health. But I was provided this fun fact that healthcare has a bigger impact on climate change than the airline industry. And I find that to be quite shocking. And then when I take a minute to think about that, that sort of starts to make sense. I was just thinking today about, I was popping in and out of patient rooms on the wards, and just the amount of personal protective equipment that you're donning, doffing, all the laundry that needs to be done, all of the containers that all of the meds come in, etc. It's extraordinary how much waste there is. So I was actually quite excited to have this conversation. How did you find yourself getting into this field? Where did the interest come from?
So I'm going to be honest, I came across it accidentally. So I was on my maternity leave back in 2022. And fun fact, don't sign up for a course when you are 1 month postpartum, because that's exactly what I did. And in my sleep deprivation, I signed up for the CMA Cascades course called Sustainable Health Systems. I somehow thought, because there's all this talk about the cost of healthcare, it was about health economics, but it turned out it was an environmental course. And it was the fact that you cited, the fact that A, healthcare even has a carbon footprint, and B, that we were actually larger than the aviation industry at just under 5% in Canada and globally. That's what inspired me to even think about doing anything about this topic. So over the course of my maternity leave, I basically talked to other physicians who were involved in the space, learned more, realized there's a lot going on in operating rooms and in anesthesia, but I wasn't sure what I could do as a rheumatologist. So even though I'm hospital affiliated, I felt like I was out of place in those conversations. So I decided to focus more on ambulatory care. So I've learned from family physicians and others who work more in the ambulatory care space. So as a whole, ambulatory care is a much smaller footprint, but it's also something easier that we can do as clinicians, because especially if you're in a non-hospital based practice, you're basically the person who decides what you're going to buy, how you're going to run your clinic, and something that can scale across all specialties and primary care.
Is there any way to explain why this should be the domain of rheumatologists in particular? Do we have a particular contribution to this broader footprint? Or is this more of a hospital-based phenomenon?
Yeah, that's a great question. So being a rheumatologist, I decided to focus on the domain I already work in. So sometimes people talk about things like spheres of influence. So what can you influence in your daily working life? So I definitely was biased towards rheumatology. As a specialty, we're very small, so we don't have a particular outsized footprint. A lot of the carbon emissions are really coming from hospitals, from ORs, so anesthesia, for instance. But what ends up happening is that we're a very tight-knit community. It was having uptake within organization levels, being able to speak to colleagues and really amplify that messaging. That is something that we have in rheumatology, which is unlike other specialties, that we're able to actually come together as a group, kind of talk about this topic. A lot of the data is still emerging or not clear-cut yet. So that is definitely a domain that we're familiar with working with as rheumatologists. So I would say as a medical organization, we're one of the really leading medical organizations as a CRA to really tackle this topic. So I've actually had a chance to present at Choosing Wisely and also share our experiences with even Australian and the American College of Rheumatology. So it's really the fact that we're a close-knit community as opposed to us having an outsized impact. But we work closely with a lot of patient partners and patient organizations. So that's a very important piece to all this at the end of the day, is how can we deliver healthcare that is practical, but also sustainable, both ecologically and economically. And also, in a way, as rheumatologists, we actually interact with industry partners, and they have a huge role, because I can say that you can have a greener product, but if it doesn't exist, that's just a very abstract concept. So in a way, there are some strengths that we have as rheumatologists, is really having that connection with patients, being a close-knit community, and across not just physicians, but across allied health professionals, and also having those conversations with industry, we can really navigate some of these areas that other clinicians have taken a different approach.
And Stephanie, on that note, I just think broadly that we prescribe a lot of medications that are shipped individually month by month to a patient. If it's a cold chain product, we've got the cooler and the packs of ice and all that stuff and disposable things in there. And it seems like there's no reduce, reuse, recycling going on. And I always think there must be a better way.
For sure. And in fact, when talking with patient groups, a lot of people actually comment on how much waste is generated, both in the packaging component. So some things are beyond our control, like medications, as we know, are manufactured abroad. A lot of the carbon footprint really comes from the manufacturing and transportation, and that's something we can't get around. But a lot of the patients are the ones who are telling us, like a single delivery can fill up a good chunk of their one-bedroom condo unit month after month. So these are the things that having those different voices is really important, because as a prescriber, I have to say I didn't really appreciate it because I just write the medication, I write the dose, I know the indication, I fill in the paperwork, but I didn't appreciate it until I was talking to patient partners about their experiences too. So these are ways that we're really talking about streamlining service delivery. How can we deliver the same medication but in a way that's more efficient? Because a lot of patients joke that every single family member and their friends all have an iced like box that they've just shared with everyone else.
You make a good point, and I think that certainly reflects my experience that rheumatologists do tend to maybe punch a bit above our weight class in the hospital compared to like our footprint of patients. I think we're fairly involved in administration, policy, interaction with industry, research, and I think that sort of that hospital-based footprint and policy footprint also means that you have influence over those things. So when it comes to provincial or national policy, but also drug price negotiations, right? And maybe as you bring forward patient input and bring that to negotiating tables, you can actually make a case for drug companies to adjust their supply chain approach or adjust how their packaging approach, et cetera. I imagine that a lot of industry functions based on what they're hearing from consumers. So if no one ever brings it up that we would like this to be not wrapped in 10 pounds of plastic just to deliver it, that might be something that's actually not a terrible burden for the company to do, but is of value to us. I can totally see how our influence of the way that, let's say, biologics, or I don't have a lot of insight into the production, but distribution, that could filter easily into IBD, into neurology, into nephrology, right? So even with a smaller national specialty, that actually doesn't mean that our voice is particularly small. So I think like that's good framing. I think that just because the individual office, yes, your personal contribution may be modest as a group, there is value in being a thought leader and pushing good practices. So with that in mind, I'd like to get into some of the kind of prescriptions that you have or some of the important tips that clinicians can use in the hospital for sure, but it sounds like maybe we'll talk more about the outpatient setting. Can you lay some of the foundation there?
For sure. This is a part where really our clinical lens can be so important. Just as a comment of what you said earlier too, is that we don't have a lot of data. A lot of it's internal data when it comes to manufacturing and transport. So it's been unknown as to the carbon emissions of manufacturing and transport for different medications and also for different companies. But people are definitely working on that information. And then the other piece too is that it's really a combination of the corporations or hospital leadership really having these sustainability goals at the corporate level, and then also on the individual level, people doing QI projects on an individual ward or how medications are reconstituted or delivered. This is a part where we can really, as clinicians, really connect that top-down approach, but also take that information, extrapolate it to different wards, hospitals, and across systems as well from that standpoint. So with that in mind, at the time of this recording of this podcast, we don't have rheumatology-specific medication information. So therefore, we also want to be able to create a toolkit that was useful, but also be able to incorporate things that were still grounded in what we know from current evidence, which is why we really appealed more to general principles. So the whole idea from the Lancet from 2021, 2/3 of the carbon emissions are coming from the supply chain. So those are medications and everything we use. Our top recommendation is to actually deprescribe. Streamlining how care is delivered. Really deprescribe is number one principle, and also the idea of delivering high value patient care. Because if we can streamline investigations and how illnesses are being managed, we're really cutting down on all I call it little footsteps that makes up our supply chain. So whether it's medications, but even also the tests we order, all the reagents, they're all coming from different places. They all have to be stabilized. They're transported. Even if you think of a test result, like first of all, a patient has to get to a facility to have, let's say, blood work done. That sample then needs to be transported. And then it might need to be transported to another facility before it gets processed. All those reagents that comes from mining or any else extractions in order to run that test, somehow through informatic systems deliver it back to us and to act on the result. You can see how there's all these little steps along the way. So that's why we appealed to the idea of deprescribing and high-value patient care, which is definitely something that any healthcare worker can do. And as part of our conversations we've had over the years through choosing wisely, but also the idea through training and also through professional development, that's what we're always trying to do. So that's why it was really to frame it not like a totally new topic that people have to learn, but really incorporate as part of what we already do in our day-to-day work.
What I'm hearing is I should stop prescribing or ordering so many cryoglobulins when I don't need them.
The key thing, though, is we're not talking about rationing patient care, which is what I really want to emphasize, but really when a test, we know, for example, like in rheumatology, we talk about not having that repeat ANA every month. Like it comes to a point where is it actually adding value to the person's care or not? And sometimes things do need to be repeated for research purposes or the symptoms change, something evolves as well. So I always tell people clinical judgment overrides any of these things that we're talking about. But until the evidence is more clear, this is where more research, like how often do we have to repeat certain tests? This is where a combination of research and really having that evidence-based lens, it all goes hand in hand. So it's not about reducing as little care as possible. It's really about how to streamline it in an effective way.
So a couple of things come to mind. First of all, because there's not a lot of rheumatologists and we are mostly urban-based, the idea possibly of us going to a remote area to do in-person care, maybe optimizing basically telemedicine and video medicine that can help patients that don't have to travel so far, and also having someone with eyes and feet on the ground, so eyes to see the patient sort of training through, such as the Arthritis Society and other ways, that someone in the community can give us accurate data. And it saves, I always think people are taking a day off with their driver who takes a day off to drive a couple hours each way, to sit in an office waiting a couple hours if it's my office, maybe less than other people's offices. And all that, how much is necessary that someone comes in person every visit. And I think that's a way that we could actually save patient time. We could save gasoline. We could really deprescribe so many in-person visits, even though, by the way, I'm a total advocate of in-person visits where possible and where necessary. What do you think of something like that?
Oh, absolutely. And in the course of a toolkit, we made sure we talked to rheumatologists of all domains, whether you're practicing in an urban or in a more rural, remote community, or even if you do different types of models of care, and also engaging our colleagues, such as those in Arthritis Society and otherwise as well. So even as a personal example, I actually do a collaboration with the Arthritis Society, where there are colleagues who are on the ground, so usually occupational or physiotherapists. They are physically with the patient on site, examining them. And then I'm actually sitting in my office in Mississauga doing the video conference so that there's someone doing the physical exam. So having engaged and talked to many different rheumatologists about this topic. So I'm also mindful that people have very different opinions, different directions of how they feel about virtual care. So I agree with you. In person is ideal from an interaction, communication, physical exam standpoint for sure. When we say virtual care, it can mean different things. So in some jurisdiction, it means a video visit. In some jurisdiction, it means phone visits. So we know by far phone visits are really not helpful. I think virtual care definitely reduces patient and their caregiver travel and also time costs, as you mentioned, in terms of taking time off of work. But I think this is where, when it's done appropriately in a certain context that is with discussion with the patient, I think it'd be really effective. So just to give a more concrete example, so I typically say in-person visit for the first visit so I can get a handle of things. But if it is someone, it's a stable follow-up. And I actually learned this from actually the BC rheumatologist at the start of the pandemic of how do you do virtual care in rheumatology? That's like unheard of, almost no way can you even do rheumatology. So for a stable follow-up patient that has literally nothing to examine or concerns, and it's just about reviewing their results and talking about next steps, or it's maybe even a reassurance, this is a normal result, there's no concerns, we're wrapping up this visit, I actually offer that option and I make that part of my discussion with patients too. Because some people say, you know what, I'd rather come in person because then I have the protected time, I could focus on what's going on. Other people love the virtual option because they're like, you know what, I can just be at my desk, I just leave you on on the video portal. As soon as you're done, I don't have to spend even a couple hours driving to your office, waiting, seeing you, driving back, navigating through traffic. So this is a part where to be inclusive and also like mindful of everyone's different working clinical context and also patient scenarios that come up, it becomes really, it seems like a cop-out, but it is true. It really is a shared decision-making with the patient in terms of what options are available, because different people will say different things. And I've had many caregivers saying, I'm so glad you gave me this option because I'm worried about losing my job with the number of medical visits I have to take my parent to, for instance. So I tell people when to actually say it's an in-person and when is it appropriate for virtual. So there is some discussions, and these aren't long discussions given a lot of patients have experienced some variation of virtual care during the COVID-19 pandemic.
It does seem like, generally speaking, we've gotten a pass both on our use of medications, prescriptions, having people come see us in person because it's healthcare, right? And because, hey, bigger fish to fry here. This person's sick, nothing else matters. And it seems maybe a focus of the toolkit and integration of Planetary Health concepts into the clinic is not necessarily, as you've said, to lessen patient care or make it less accessible for people to come see you in person. It's actually just that we can do more than one thing at the same. We can walk and chew gum. We can think about these concepts as we are going about our business. And I also think, like you've pointed out some really good scenarios, but even just for ease of running a clinic, if you've seen someone and you're going to start them on methotrexate, but you want to check their kidney function and liver enzymes or whatever first, the follow-up appointment can reasonably be a telehealth to start the medication after you've seen them to examine them. And certainly I think most rheumatologists would say they definitely have places where telehealth has been quite valuable. Another one that's just off the top of my head from today, the patient lives here, the family lives in New York, but they want to be part of the conversation. They can't all come into the clinic. That's an unreasonable ask. But you can do that by telehealth with relative ease, and then you're really bringing the whole family into it. So there are some easy ways to integrate that in no way interfere with like good patient care, even though, yes, in some ways it's easier for me to see people in person. And there are certain cases where it can only be done in person. It's not an option to do it by telehealth. But there are clearly cases where it's valuable to do it by telehealth as well. You were telling us about deprescription. And I was wondering if you had any kind of specifics to offer in terms of, are there certain culprit medications? Are there certain culprit tests that it is truly wasteful, and rheumatologists do this a lot? Is there anything that you can point us to specifically?
So I'm not going to point out one specific rheumatology medication, but I would say we do have guidelines and guidance and evolving data in terms of the idea of even tapering certain medications. So specifically, being an adult rheumatologist, really the idea, if someone is completely stable from their rheumatic disease, it's been years of remission, the patient's going to probably think about tapering on their own. There is data to guide like what you taper first. Is it going to be their advanced therapy? Is it going to be their CSD MARDs? How do you go about it? So there actually are CRA guidelines on this as a decision aid. First of all, how does the patient feel about all this? Because there's always a risk of having a flare. Are they going to be able to access care during a flare? So I always tell people, don't do it before you're headed on a multi-week vacation. And also in terms of the risks to their specific disease, what their flare would be. Are we talking about swollen joints? Are we talking about some organ-threatening manifestation? So really tailoring that advice is very helpful. So I would say broad approaches is really in terms of medications. And that's where the research and the data is depending on certain diseases, certain period of remission, and also really engaging the patient. Because I've had patients that say, first of all, sometimes they call me because they've self-stopped their medications and they're flaring. But for anyone who's in remission, at least for myself, I actually put it as part of my conversations, being like, are you thinking about tapering? And some of them have tried and they said, I did it for 2 weeks and I flared and I went back on it. And I'm like, oh, thanks for telling me that. Or some of them are thinking about it and some of them are like, I remember how I presented. I never want that again. And they don't want that. So there is a risk threshold, both in terms of the patient's sense of risk and also how they feel about their medications. But then I also give my provider opinion. You know what? It's been going 5 years, your RA's been stable, maybe we start with a dose taper. I usually do it very incremental, very gradual, nothing before any major life events or if they're going to be away. And then I give them advice in terms of what they do when they flare. Typically it involves going back to their previous dose, when are the symptoms to be worried about, when they should be calling me versus going to emerge, for instance. So I would say DMARDs in general, there is emerging evidence on that. The other components too, we always target, the way I've been indoctrinated through training is try to get rid of the prednisone. Why are they on prednisone? There's so many other options as well. So prednisone and NSAIDs are definitely another one that we should ideally really not having people on that on an ongoing basis. I'm pretty sure if you ask most rheumatologists, they're like, yeah, my patients are definitely not on NSAIDs and prednisone, but I think some chart audits will probably reveal otherwise. So there are medications that we definitely use. But another obvious other one that we commonly use is PPIs. And this is not specific to rheumatology. People are often on PPIs for much longer than they need. But with PPIs, a lot of people get a rebound dyspepsia. So I didn't appreciate until I learned more about deprescribing. There are actually resources in terms of learning how to deprescribe, because I did not appreciate that people had a significant rebound dyspepsia with tapers. So therefore, certain things, even for my own education, to taper half dose gradually, and then also other options they can use to replace their PPI. So they're not demoralized in that first week when they're having all their dyspepsia and wondering why you're doing this to them. So I find that there's a combination. So I would say PPIs, NSAIDs, prednisone, definitely go-tos. But there's also data when it comes to DMARDs in certain specific patient contexts too.
Couple pearls that I've thought about is I really believe we do way too much regular lab monitoring, and there are country ranges and there's what we're taught to do. And I think a lot of us go monthly for a little bit on a new drug that could be immune suppressing or gives cytopenias, transaminitis, etc. And then we go to every 3 months. But some of the GI colleagues or others, they're going as for instance, every 6 months. We don't need all of these specific labs. Some people order 10 things. Some people complete blood count, CRP, ALT, creatinine. So there's a real range. And the other thing where I think I've tried to really eliminate waste is a fast on, fast off drug. If I'm starting something new, you did talk about NSAIDs, and sometimes I am for sure prescribing them. They work in a matter of days. If you're going to use a CCB for nifedipine for Raynaud's, they work in a matter of days. So I usually give a small amount to say, number one, does it work? Number two, is it tolerated? Then here's your giant refill if it's a winner. Otherwise, I always think of the waste of, because I'm not sure it's always destroyed by a pharmacist. I don't know if it's flushed down the toilet or in a cupboard in the back shelf of someone's like medicine cabinet for the rest of their life. But there's a lot of meds that are not in the mouths or in the injections into the body of people. And it's a total waste of product. It's an environmental waste, etc., packaging and things, a financial waste too. So I do try to think things that are reasonable, obviously GCP always, but that sometimes less is more. And then talking about, I see you're on 8 other meds as well as all the ones I'm prescribing for you. What are you on some of these things for? They seem to be, in my opinion, a bit redundant. Could you talk to your family doc, primary care, other specialists about possibly changing it up and having to be as well taking a bit less stuff? And that's a longer conversation, and it's out of my area of expertise when I do that. But I think those sorts of ideas, just being conscious that if it were me and if I could do just as well on 6 meds as 12, you know what I'd vote for. If I could get more of a supply on a refill than less, if it's something I'm on chronically at a stable dose, I would vote for that as well instead of going to the pharmacy. And also, if we want to increase adherence, having the availability to have your drugs easily obtained when you need them is a nice idea.
Absolutely. And I agree. And I've definitely done that too, where, for example, even like with prednisone or NSAIDs, I'd rather give them a small supply and then 1 or 2 refills so they had something to tie them over, and then educate them about flare symptoms. And when it comes, but there's always so many details I find that I don't even think about when we've had these conversations within our task force, which is the idea that someone picks up fewer of their medications. So in some jurisdictions, prescriptions, depending on how their medications are covered, they might actually want to pick up a large prescription because they pay less of a dispensing fee. Others might actually say, you know what, I'd rather pick up a small supply. So that also becomes a conversation. So that's why having that range of options, it becomes a conversation for people. But I would say a huge thing that we can definitely work on, aside from not just deprescribing medications, or maybe making a mention of what are you on this for? And sometimes, for example, aspirin for primary prevention for cardiovascular disease, like that's, some people are still doing that. And I'm like, no, you don't need to. It has that conversation and how I understand someone's past medical history, but also deprescribe vitamins. I find they're not on medications, but they're on many different supplements. And some of these supplements have not been demonstrated benefit, and some of them even have potential harm. So I actually have used that opportunity to have that conversation, because they might not think they're taking medications, but they're still taking handfuls of capsules. And there's a huge manufacturing process to that. And when it comes to blood work, this is a part where some of my colleagues have said, I would do less blood work if there was guidance, because they feel like medically, legally, they can't do less blood work. And this is a part where sometimes patients decide how often they're doing blood work despite what we write on the requisition. And we know that during COVID is that people did less blood work. Labs were closed, and most of them anecdotally did fine. So this is a part where having an agreement as a community of what would most people do, what does the information say, this is definitely an opportunity to be able to reinforce people's confidence in how they practice too. Because I think ultimately people want to order less things, but if they don't feel like they should be, or if there's other factors driving it, such as patient requests, I think the inclination is that people would want to order a lot for that reason.
This isn't to dunk on them, but I've certainly seen, like, when dermatology prescribes a biologic or even methotrexate, they're a little bit more liberal with the length of time between getting blood work checked and in some cases not checking it at all. And on the one hand, my gut instinct is to say, like, hey, these are powerful medications. You got to keep a close eye. And on the other, feeling a little bit of envy that they really felt that confident that these are largely safe medications. And for many of our medications, we even intuitively know if you see a small change, what many people would do off the bat would be, we're going to repeat it and see if it's a trend or if it's just a blip. And if we're doing that, then isn't the main concept that a lot of the abnormalities we are seeing in blood work are things that will resolve on their own? They may or may not be related to the medication, and you observing it is the morbidity, right? You and the patient finding the ALT bumped up a tiny bit is actually not helpful. It is, on a micro level, harmful. But if you weren't going to act on it anyways, why did you send it? And Janet, in a very long ago past episode, explained that when she's assessing a patient, let's say with rheumatoid arthritis and going to start methotrexate, you were not impressed by the evidence around getting a baseline chest x-ray, right? Because you felt if it's not clinically apparent ILD that this person has, then why am I trying to find it? That's not going to change how I'm going to treat them. And I'll be able to tell if the methotrexate causes pneumonitis, so I can tell that clinically. And if they have granulomatous disease, methotrexate isn't really a major risk for reactivation of that anyways. So why are we all doing the x-ray? But we're not that comfortable until there is guidance from on high, generally speaking. We really do want there to be consensus before any of us go out on a limb. And I think maybe that is the same here. I don't want to be an outlier when it comes to monitoring. I would feel quite uneasy.
And I think guidelines have to be what is optimal safety and benefit, but not what's, pardon my language here, but not what's CYA, cover your butt. Because I think really a lot of guidelines have that sort of innuendo in that we're telling you to be a good prescriber or a good treating physician or whatever, that these are the steps you need to do. And then when you find, even if there's high consensus, if you actually look to the data that drive it, it's often our interpretation of old studies, different dosing, different times, etc. So sometimes it is something, it's a kickback of things that used to be where cirrhosis did occur with people on methotrexate daily. Cirrhosis still occurs in our patients, but it's often a different reason. It's not even so much the drugs or even the use of alcohol. Of course, it could be either in some patients, but it's fatty liver disease, so MASH, NASH, NAFLD, etc. So I think those sorts of things we probably do need to reassess literature, have guidance, and say, you know what, it's okay once you have cytopenias usually come early. So once you are beyond an early phase of using a drug, cytopenias can occur, but they're less. When if you're starting a new drug, you're going to do tests again a little bit more, and then back off again. And transaminitis comes whenever it wants. But in general, over the course of treating someone, I don't think most transaminitis we act on, as you said, Daniel. And then you go, why am I doing all these tests? And what are my rules in place? I tell patients that I only call them when the ALT is greater than 100. So 3.5 times the upper limit of normal. Because then we're calling to say, oh, are you sick? Did you start an antibiotic, a new med? Were you on holidays and really having a few drinks, etc.? So it's usually something that's very transient. And I think we sometimes fool ourselves that looking at the rising MCV, which to me means adherence on some of our drugs, and looking at a normal ALT, that, oh, then this person's not going to get significant liver disease. And I think we fully well know that sometimes it's almost sporadic appearing, even though it's uncommon, and I don't want to scare prescribers or patients if they're listening. There's a lot we do that is based more on eminence than evidence. And I think that's the kind of deep prescribing that once you kind of know your patient population, you're probably a little bit more comfortable with years of practice and knowing, oh, I have really high risk people for this or that because of the community or the types of patients that I'm practicing with, or even the diseases I'm looking at. So I think there is so much blood work that is really a total waste of time.
For sure. So that's why I would say for the toolkit, there's a lot of things that we are still waiting for in terms of whether it's going to come through like more QR projects or more research or surveys in terms of establishing consensus. We did also want to make something more practical that people can actually implement and do. So they weren't like, this is interesting, but I don't know what you want me to do with this information. So we actually provide some tips on terms of how people can green their own offices. And when I say that, I don't say we as in the clinicians. I tell people we actually purposely made the toolkit. The original title was for rheumatologists, but we actually changed it for rheumatology to be inclusive of the community. But also the fact that a lot of these things can be done by clinic managers, really hospital procurement departments in terms of streamlining things. So again, it's not going to make or break the planet, but I always use the example that everyone loves, which is exam table paper roll. We see it very commonly in most clinics. It's almost part of the experience, but there is evidence within family medicine that the high touch surface of the table is actually the side of the table, which is totally not where the paper covers. And I actually looked into some IPAC literature when it comes to low risk ambulatory care settings such as rheumatology, where there's not a lot of bodily fluids. We're supposed to actually wipe those surfaces down. But again, in ambulatory care, whether it's rheumatology, whether it's OB, whether it's family medicine, we haul that sheet of paper. It's what my ID colleagues hygiene theater. It doesn't even actually protect the patient. If they're fully clothed, we're essentially using as a chair. And if they're not, we really should be like sanitizing the surface. So that's an example of really an idea of like cost savings, just getting rid of things that we historically have always done, but doesn't really contribute to patient care, which is like getting rid of exam table paper rolls. The idea that I started doing during pandemic as well is like fax the prescription directly to the pharmacy. So the prescriptions don't get lost. You have an idea of where it went, who their pharmacist is. If you need to communicate and you can't get a hold of the patient, that's always a backup plan. So these are all different ways that we can really work with the practice management piece, whether it's practice in terms of the clinical practice or like the office, whether at the hospital level or otherwise. So even in urban settings, another topic that often comes up is the idea of reusable gowns and linens. So hospitals have the economies of scale. So usually in an urban setting, typically it's actually cost savings to have laundry gowns and linens. Whereas if you're in a more rural setting and there's some transport, it might come across as cost neutral, for instance. And this is a part where, as the clinician, where we're really thinking about the system overall and the patient in front of us, is really going to, whether it's someone in procurement or others, or telling someone else to mention that this is something that is important to our system as a whole, because there's procurement, which is like the purchasing of things, and then there's waste disposal, because we know that a lot of hospitals these days are running deficits. And if they can cut down the amount of money they spend on waste, or how, let's say, even how medications are delivered or disposed of or thrown out, that can really streamline that we can dedicate more of our resources, even economically, towards patient care, which I think is very timely as a topic too. So that's why I really tell people planetary health, or the whole idea of sustainable healthcare, is really not a separate concept. It's really something that can be infused in our day-to-day work, because we can talk about cold chains and whatnot, but someone's not thinking about that if they don't have access to their pharmacy, or if they're evacuated, as we've seen in Jasper, Yellowknife, and so forth. We are managing people with chronic illnesses.
I can imagine that there are probably some listeners, rheumatologists or otherwise, who hear this and largely agree and just feel like, what's the benefit to me right now? Why must I take on this burden?
Oh, for sure.
Yeah.
And I tell people at the end of the day, if you are like on the verge of burning out and you're like, I'm so busy, I don't want to learn about another topic, that is actually okay. Because really the principles that we've been emphasizing is deprescribing and high value patient care. Those are things that they should already be doing. So sometimes I tell people, they're like, just tell me one thing, I'm really busy. I'm like, deprescribe, use less stuff. And they're like, got it. And that's all they need to do. They don't have to like spend hours or really spend a lot of time and investment on this. And just to plug it, stay tuned. Later this fall, you'll be hearing about Rheum Bingo, and details are currently being sorted out by the task force, but we will be launching a friendly competition / inclusive fun event called Rheum Bingo, where we'll see who is interested in greening their office in a totally achievable way. So stay tuned, more details coming for this fall. So if you're motivated by bragging rights, that might be another motivation too.
That was the third category that I forgot to mention, bragging rights.
Of course.
Bragging rights and being featured in the weekly presence update is a tentative idea.
So you've taken us through the toolkit. You've listed the top 3 things healthcare workers can do: deprescribe, efficiently deliver high-value patient care, and we covered it a bit earlier, but advocate for environmental stewardship in healthcare systems and service delivery. All of this is included in the toolkit, as well as, in addition to example checklists, a summary of high-yield actions. I would suggest that everyone listening take a look, because there are things that are, you've given us a sample, some very easy adjustments to make in clinic, but also broader concepts that you cover here, including diet, transportation, buildings and energy, education, personal choices, and advocacy. And some of these may appeal to different people for different reasons, but all of this is included in the toolkit that's on the CRA website. And did you have any kind of last thoughts that you wanted to share about this Planetary Health or the toolkit itself?
Yeah, for sure. I would say, if anything, it's really appealing to people in their clinical lens. So don't lose that, and don't you lose the critical perspective as well. So I think as more data becomes clear, we know where the big picture and where this is all headed, but how can we personalize our day-to-day work and also personalize our discussions? If you're in a wildfire zone, you're going to personalize those discussions to someone who's more in a flood zone as well, and how you would adjust it. So you don't want to go down the rabbit hole of like doomsday all the time. You want to also make it practical and also something that's actually going to happen, as opposed to theoretical risk. But ultimately, I would say the takeaway is Planetary Health is really about streamlining high value patient care and also cost savings. And ultimately, it also is environmental sustainability. So that's the good news. You have the benefits of all 3.
Stephanie, thank you so much for coming on the podcast. We really appreciate you outlining the good work that you've been doing on the toolkit and the advocacy that you've been doing around Planetary Health. And I'm looking forward to that bingo.
Perfect. This is definitely a shared effort by all of us.
It is, but you've spearheaded it. It's great. And I agree. Everyone should look at the toolkit, pick 1 or 2 things, and go from there.
Thanks very much, Stephanie.
Thanks for having me.
That's it for this episode of Around the Rheum. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag us on social media. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for all their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. And share this episode link with your colleagues. It helps these interviews reach as wide an audience as possible. Until next time, with Janet Pope, I'm Daniel Ennis. Thanks so much for listening.